Pediatric Airway. From Dr. Ankush Malhotra MD Anesthesiology Anesthesia Blueprints. Hi. My name is Alicia, an assistant of Dr. Ankush Malhotra. The neonatal airway has numerous anatomic differences that must be accounted for. For an anesthesiologist, it is must to know about pediatric airway. Difference and implication. Proportionally larger head and tongue with a shorter trachea and neck than adults. The large tongue may make mask ventilation difficult and necessitate use of an oral airway to relieve airway obstruction. See image. Large occiput. The neonate's upper airway is susceptible to closure, especially if the head is flexed when lying supine due to the relatively large occiput. See image. Shoulder roll and implication. Use of a shoulder roll may help open the airway and improve visualization of the glottic region. 1. Glabella chin plane should horizontally aligned. 2. Neck should wide and open. 3. External auditory meatus and suprasternal plane should horizontally aligned. Level of larynx. The larynx is located more cephalad C4 versus adult level of C5 with an epiglottis that is short, omega-shaped, and angled over the glottic opening. The larynx in a preterm infant is even more cephalad, located at the C3 level. See both images. Anterior commissure and implication. The anterior attachment of the vocal cords in infants is more caudad than the posterior attachment, in contrast to the adult vocal cords that are perpendicular to the tracheal axis. When placing the tracheal tube, it often becomes hung up at the anterior commissure. When placing the tracheal tube, every effort should be made to introduce it through the posterior aspect of the vocal cords. Narrowest portion of airway. The narrowest portion of the airway is the cricoid cartilage, necessitating performance of a leak test around a cuffed or uncuffed endotracheal tube, with an ideal leak less than 30 centimeters of water but greater than peak airway pressures. Summary. Large occiput neck flexion leads to airway obstruction. Roll under shoulder. Relatively large tongue difficult mask ventilation and may need oral airway. Cephalad larynx difficult visualization of vocal cords, so straight laryngoscope blade necessary. Floppy epiglottis obstructing view of vocal cords. Use straight laryngoscope blade to lift epiglottis. Vocal cords slanted tracheal tube hung up at anterior commissure. Cricoid cartilage narrowest portion of airway. Perform leak test of tracheal tube less than 30 cm H2O or greater than peak airway pressure causes post-extubation stridor. Thanks for your patience. Dr. Ankush Malhotra MD Anesthesiology Anesthesia Blueprints. Contact for Anesthesia Blueprints notes at